Hey, everybody, Saul Marquez with the Outcomes Rocket. I want to welcome you back to our podcast today. I have the pleasure of having Katy Lankester on the podcast. She is a health tech product leader on a mission to make it simpler and more affordable to deliver and receive high quality care. Currently, she is an advisor at Redesign Health, where she supports early stage health tech companies with product strategy and value proposition, data acquisition and management, and many other things that involve going to market. Katy began her career in a variety of for-profit and nonprofit settings across the U.S. and globally. And so excited to have her here on the podcast today. Katy, welcome to the Outcomes Rocket.
Thanks so much, Saul. I'm thrilled to be here.
It's a pleasure to have you here. And so before we dive into, some of the work that you do on the advising side, talk to us about what led you into healthcare.
Yeah, it's funny that it took me a while. I think we all find our paths differently, but in retrospect, it should have been obvious. I come from a family that's worked in health system design, both on my mom and dad's side, but I really trace it back to a personal experience. I love the outdoors, and I was doing a technical ascent of Mount Shasta, and we had an accident. My guide was hit by rockfall, and we had to quickly organize a really technical evacuation. So picture, a sled on a snowfield and a helicopter to 8,000 feet and all of this. So fortunately, it turned out well. He made a full recovery, but it really built in me an awareness that I needed to have some skills. And it started me on a path to becoming an ambulance volunteer, becoming a wilderness first responder, and just having a passion for emergency medicine in general. And then I think, like many of us, we start to work in the field and we have a desire to maybe solve things at a more systemic level. So I kind of worked through some time at international public health, and then, realized there was a lot of work here to do back in the United States, and have been kind of focused here for the past decade, really enjoying getting to be in the field at a moment that's so dynamic and interesting.
Yeah, I couldn't agree with you more. And wow, what a story! So you were 8,000 feet up. Are you that's like intense? That's intense.
It was, and I was 16. So,
oh my gosh, that's incredible. That's incredible. Well, glad the outcome was good, and certainly those life-changing situations that could push you in any direction, it pushed you into healthcare. And today you're very focused, it sounds like, on value-based care. So talk to us about what you see as the promise of value-based care contracting.
Yeah. So I think it's, I've worked at kind of lots of different parts of what we talk about as value-based care, right? We can just, let's say, for the sake of argument, we're just talking about aligning provider incentives to quality and care cost reduction kind of writ large. And the promise I see there is really that it's taking two historical players. You've got the provider who's seeing the patient, and then you've got the payer who's really seeing the patterns, and it's putting them on the same team. And they haven't historically always been on the same team. Kind of over the past decades, there's been this sort of, it might be dramatic to call it an arms race, but like everyone's grabbing tools to try to figure out how they maximize reimbursement. And it hasn't ultimately been really at the best interest of the patient. And it's helped drive a lot of what we see in this like massive administrative expense, that sort of bloating for healthcare costs. So for me, the promise of value-based care is really allowing a lot of innovation in care models that are focused on improving outcomes, and then creating ways for those to be paid for that bring together the payer and the provider kind of on the same team with a really aligned collaborative structure. So that, I think, is really exciting, but of course, it's also very hard.
A lot of pain points in that process. Many times, payers and providers are at odds. Reimbursement and denials, and
prior authorizations, and it's payment integrity programs. They all have the best intentions, but when you start to layer them all on top of each other, you get an administrative nightmare.
Yeah. So let's talk about some of those barriers. What are they? How do we overcome them?
Yeah, I actually want to just really kind of focus on the contracting process, because I think it's one of those really, it's not the sexiest part of the problem, but it has some major barriers to really helping us accelerate the value-based care contracts, and particularly the ones that are going to be more of those upside downside risks, which are still, lagging behind as kind of part of the overall market. So value-based care contracting it's really hard, right? And two of the reasons it's really hard are the transaction costs to get it done, and kind of related challenge of the data access to be able to make it happen. So if you think about, there's a recent post from Emily Walker, actually, that does a great job kind of talking through her experience at Geisinger and Elevance doing this work. And she talks about, her analytics team used to get 36 data requests a week to support the value-based care contracting process. And those had a 12 to 48-hour turnaround time. So you're talking enormous numbers of man hours to be able to facilitate the process.
Mm-hmm.
And on top of that, that then kind of extends the overall calendar time, right? You might get a fee-for-service contract done in maybe like 3 to 6 months. Value-based care contracts are taking sometimes 9 months to 2 years. It's like 3.5 to 5 times longer. And that's a real drain on being able to make these happen.
Yeah, it's a huge drain, and I think a big reason why there hasn't been as many as there could be, and there's a lot of, I think, appetite for doing it, and certainly we're moving closer to that. So talk to us about solutions that could be emerging to help with a lot of the friction that exists on just getting started.
Yeah, you're exactly right, Saul. There is some really new and exciting emerging technologies around this. The company that I most recently was working with called Nuna Health is one. There's also Syntax, which is where Emily Walker, who I just mentioned, is a co-founder. Apported and Edifex are two others, and there are more out there, I'm sure, but those will give you sort of an idea of the fact that there have been a lot of new entrants.
Mm-hmm.
And all of these folks are coming forward with solutions within the past, say, 3 to 4 years. So it's pretty new. And a lot of the health plans and even some of the other more specialty physician groups don't necessarily know that they're there. And what these tools generally do is they're going to help both entities be able to better understand and model the different types of complex contract terms on either a sort of corpus of like generic industry data, or potentially on your actual claims data and claims experience. So one of the ways these tools can vary is based on that sort of element. Like, is this your data or is this a more general data set? But ultimately, they'll help you be able to sort of see a shared understanding of, like, let's look at who the population might be. Let's see what happens if we exclude a certain subcategory of spend, which is a common thing that happens during contracting. You pull off certain spend categories, or you change your attribution method. Hey, show me what would happen if we attributed based on geography versus, say, most recent primary care visit. These are the sort of brass tacks of what's happening in the contracting process. And you can imagine it's really difficult to see how all those things are interacting when you're trying to manage the whole process with spreadsheets flying back and forth and data pulls that maybe use slightly different logic, and you realize you made a mistake. You got to go back to the drawing board. So these tools are helping to pull all that together, put it in one place, and often allow it to be a shared conversation between both sides of the contracting party.
Folks, we'll leave them in the show notes so you could explore them. Maybe you've heard of them, and this is a reminder that you got to check them out further. And maybe you haven't, and you want to get these contracts into place, operationalize them in a lighter way. Check these out. I think it's great tips here, Katy, that you've shared with us. Any tactical advice on adopting one of these solutions?
A couple things that I would suggest that you look for as you're trying to understand what value you're going to try and get out of this tool. And this is really going to depend on things like, are you a large integrated delivery system that is engaging in lots of different contracts with multiple different payers? Are you a smaller, more specialized, organization that's looking to take on risk for one very specific population, but you want it to be a sort of standard contract that you're signing with everyone you're working with? Are you a health plan that's actually managing hundreds potentially of contracts with provider organizations? So remember that these tools, I think, work for everyone. Think about what your organization type is and what you might need. And then I think sort of some kind of really practical questions are going to be around, are you willing to actually share your data with this organization? Because that, one, there's some additional risk, but there's also additional tooling and investment. You've got to actually create the ability to do that. And do you want to do it one time, or do you want to have that be an ongoing, you're updating data regularly? So that's going to be one thing to think about. These different organizations vary in how they'll partner. You want to check and see if they support the type of contracts you're interested in. So are they only doing, a primary care model? Are they doing episode models? Can they support, the situation where you might be in multiple types of models at the same time? So look for that. And then think about what part of the contracting lifecycle you want help with. Do you just want help upfront with that modeling and analysis? Or do you want someone who can then push those contracts into execution and potentially even take it all the way through payment and settlement? So these tools are all evolving, and I imagine they each have very ambitious roadmaps, but they're at different stages of development. So you can kind of look to some different capabilities that they might have. And then the last thing I'll say that's a little bit of a gotcha is, do you want them to help you with existing contracts you already have? Or are you going to only be looking at them to support new contracts that you're going into? Because that's going to actually really affect your implementation timelines.
Folks, that's the beauty of our show notes. We'll leave some of these tidbits that Katy has shared around considerations and how to adopt some of these emerging technologies to help you and your health system, or you in the contracts you're putting together with your health system partners. Do it in a way that's thoughtful. So check out the show notes. We'll also include the post that Katy mentioned during our discussion, Emily Walker's post on these topics. And folks, there's opportunities for value-based care today. It's just doing it the right way. And Katy, if people are curious about getting to know you better and maybe connecting with you, what's the best place they could do that?
LinkedIn is probably the easiest way to reach me.
Love it. Love it. Thank you, Katy. So folks, we'll leave Katy's information here in the show notes so you could check out the work that she's up to. Reach out to her. Do not stop at just listening. You can get into the rocket too by taking action. So Katy, I want to thank you for taking action and being with us today.
Yeah, it was my absolute pleasure. Thanks so much, Saul.
It's a pleasure.